Hi, Robert Cerfolio in New York City. This is a gentleman we've operated on before, actually, with a thymoma, who at the time we discovered a 9.5 centimeter gastro-intestinal stromal tumor, and he's been treated with Gleevec. And of course, the time you operate on people who are on, whether they're on neoadjuvant therapy for lung cancer, or even this, is when they have achieved the maximal medical therapy, meaning their tumor is no longer shrinking or the max SUV is no longer falling. And that's what happened. It now went down to about 7 centimeters. And now we're going to show you the video starting now. So you get into his chest, and it's not subtle. You're going to see this very large tumor here. The lower lobe is stuck a little bit to the back. We take all these adhesions down. We want to do a complete, careful R0 resection and make sure we're way away from the tumor, which is what we're doing now. And there you can see the capsule around his gist that was stuck to the surrounding tissue, to the aorta, the lung, multiple vessels, which we're going to dissect out. And obviously this tumor is gelatinous because most of it's dead because of the efficacy of the neoadjuvant Gleevec. We're now dissecting out the entire tumor. And when people say that you need to take the esophagus here, I've never had that happen. I absolutely categorically disagree. We're saving the vagus nerve. So here is the cranial nerve 10, and we get a loop around it. We completely save it. Again, I have colleagues who say you need to take 10. No, you don't. These tumors rarely grow into nerves, and here's the entire vagal nerve being completely dissected free, looped, and preserved. Now, of course, it is growing to part of the esophagus, so you need to free it up. Again, this is a big, thick capsule around it, and the big trick that we've talked about now for over 20 years is putting a suture in it in an orthogonal direction, one going one direction, one going the other, and then using blunt dissection to completely remove it from the underlying mucosa. You know, it doesn't invade into the esophageal lumen. So if you're just careful here, you can carefully dissect it out from the surrounding tissue, off the aorta, off the back of the remaining esophagus. Now that you're splitting some of the esophageal fibers, and there's the tumor, most of it necrotic. We're going to use blunt and sharp dissection to completely remove it from the surrounding esophagus. Now the tumor's out, it gets put in the bag, it's done. And now you look and see what damage you've done to the esophagus. So I don't run this anymore. This is important. I used to run this with a barbed suture like a Stratafix, and I had a leak. And I've had colleagues with leaks who I coach. And so now we just do interrupted silk sutures as we showed at the end of the video. I think we put 12 or 13 interrupted sutures there. We take the vessel loop off the vagus nerve, cranial nerve 10, it's preserved. I take the tube out in the OR. I don't use a Blake tube and measure amylases. I don't leave the chest tube in. You can get a swallow immediately that day, make sure it looks good. He goes home the next day. But we are restrictive on the diet, very soft diet for 7 days, jellos, yogurts, things of this nature, oatmeal, nothing with any sharp edges, no meat, no chicken for a good 3, 4, 5 days, and then he's back to a regular diet, chewing carefully. He did great. Thank you, Robert Cerfolio. Honored to have your time.